Let's get started. So, hello. Welcome, everyone. Thank you so much for joining us for the next installment of our Evolution of Mindfulness series. I am Frances Saadeh, and I am the Associate Director of Non-Degree Programs here at Brown University's School of Professional Studies. It's really meaningful to see so many of you here online, ready for today's conversation. Our audience is now up to nearly 400, and it's continuing to go up. So we should have a pretty sizable group representing a range of fields, mindfulness teachers, clinicians, researchers, students, as well as many of you who I imagine are brand new to meditation or simply curious about what mindfulness is and how it may help. Some of you may be joining with very real challenges in the background, chronic pain, stress, anxiety, burnout. And so I just want to name that and honor it. So wherever you're coming from today, you're welcome here. So thank you for being here. Here at the School of Professional Studies, our mission is to serve adult learners and professionals through programming that is both rigorous as well as practical, designed to support meaningful change in the world. Our mindfulness offerings are developed in close partnership with the Mindfulness Center at Brown University's School of Public Health. And these programs are grounded in contemplative traditions as well as scientific research. Together, we deliver high-quality, research-informed programming that supports individual well-being, professional growth, and the broader movement towards collective care. For those of you who are joining us for the first time, this speaker series explores how mindfulness continues to evolve, how practices rooted in contemplative wisdom are being studied, adapted, and brought into the world as it is, shaped by science, by systems, and by real human lives. Today's session is titled Change Starts with the Body, Interoception, Mindfulness, and a New Path for Healing Ourselves and the Healthcare System. Many of us, whether we come as practitioners, professionals, or simply human beings, we've learned over time that change doesn't happen through education or insight alone. It happens when the body is included. So when we can sense what's here, when we can meet discomfort and steadiness rather than bracing or running or collapsing, when what once felt too much becomes workable moment by moment, that is when change takes place. Our guest today is Dr. Zev Schuman-Olivier. He has helped lead a powerful shift in how mindfulness is understood and delivered, bringing interoception, that is the sensing of internal bodily experiences, into the center of healing and behavior change. For those of you teaching or practicing mindfulness, this is deeply resonant. The body is not just a backdrop. It is often where the most honest information lives. And for those of you encountering these ideas for the first time, interoception offers an accessible entry point, learning to recognize the signals of stress, safety, tension, and ease, and how these signals shape our choices and our health. Zev's work also speaks directly to a question many clinicians and community members grapple with. That is, how do we translate mindfulness from something people value into something the healthcare systems can actually deliver ethically, accessibly, and at scale, especially for people living with trauma, chronic pain, and addiction. Zev's work has done more than just make the case conceptually. It has helped build the infrastructure, testing models, training clinicians, and demonstrating that mindfulness can be integrated into primary care as well as mental health settings in ways that are trauma-informed, evidence-based, and sustainable, so that people aren't required just to have privilege, spare time, or perfect conditions in order to benefit from these practices. And now a bit more about our speakers. So Dr. Zev Schuman-Olivier is the founding center director of the Cambridge Health Alliance Center for Mindfulness and Compassion. He's an associate professor of psychiatry at Harvard Medical School and a board-certified addiction psychiatrist. His research and clinical work spans mental health, primary care, and telehealth, and includes major efforts to integrate mindfulness into real-world healthcare delivery. And he's joined in conversation today by Dr. Eric Loucks, Director of the Mindfulness Center here at Brown University and Professor of Epidemiology, Behavioral and Social Sciences, and Medicine. As he's done in the past, Eric will guide our dialogue today. And so as we begin, I want to invite you all to let yourself arrive, maybe even noticing what's present in your own body right now. And as we take a step into a conversation about the body. So if questions arise as you're listening, we welcome you to submit them. We just ask that we reserve the chat for engagement around the talk today, and then you can use the Q&A feature found at the bottom of your Zoom screen to submit your formal question. That just helps us kind of keep track of the engagement and the questions that we can bring forth. We'll have some time towards the end of the talk to hopefully get through a handful of those. And a quick note, today's session is being recorded. As we've done in the past, we'll send out an email sometime 2 to 3 days after this with a link to our YouTube playlist. And with that, it is my pleasure to turn things over to Dr. Loucks and Dr. Schuman-Olivier. Eric and Zev, thank you so much for being with us, and thank you to everyone for joining online.
Great. Yeah, thank you, Fran, for the introduction, and thank you, Zev, for joining us.
Thank you for the invitation. Thank you, Fran, for such a nice introduction.
Yeah. So, Zev, we've had many conversations over the years. I feel like we kind of grew up together in a lot of ways in the mindfulness science field. But today, our conversation's informed by over 60 questions that were submitted before the talk, let alone the energy of 650 plus people here live. Along with who will watch it afterwards too. So really grateful for you to be here, grateful for the audience, for all of you to be here too, and please don't hesitate to submit your questions. So with this speaker series, we always start and finish with a similar question. The one that we start with is just asking you, Zev, like what first led you to mindfulness yourself?
Well, I guess it's worth saying that I started out as an engineer who was not that in touch with his body. I ended up leaving my engineering master's thesis and went to China for 4 months. And when I was there, I was traveling with somebody who had some experience with mindfulness. And I was constantly uncomfortable, on the buses, with the bugs in the room, and he just wasn't. And I really, I guess I was jealous about that. And I wanted to understand it. It opened my mind, made me curious, like, what is this thing that he's doing? So I ended up going on a 10-day Vipassana meditation retreat, actually right before starting my 3rd year of medical school and starting my trauma surgery rotation. I went right from the retreat into the overnight call. But that 10-day retreat really impacted me and really changed the way that I related to my body sensations. The method that I learned was by S.N. Goyenka, and it was very much focused on mindfulness of the body and changing nature of body sensations. And I felt like it shifted the way I self-regulated. It helped me change behaviors. I met folks there who had impacts on addiction recovery, and I really wanted to understand what had happened, and got very interested in both in an interoception. What are these body sensations that I'm experiencing, and also really wanting to then understand how to make this impactful experience something that could be accessible to everyone. And I think that's where a lot started for me.
Yeah, great. So you have personal experience with developing interoceptive awareness in yourself, maybe starting at what you felt was maybe a lower baseline, and now it's heightened through deliberate training.
Yeah, I mean, it's worth saying what I mean by interoception.
Yeah.
Because there's, and I saw some of the questions that came in and were around that. So maybe I could start there and then get into some more about my own experience with it. But I think of there being a narrow and a broad definition. Sherrington came up with the idea of interoceptors, which are receptors in the body that might pick up internal sensations back in 1906. And then in about 2000, And two, Bud Craig talked about this narrow definition of interoception being sensing the internal body state. But over the last 20 years, we really have shifted that definition to a much broader definition of interoception being about not just sensing, but also interpreting, integrating, regulating internal body sensations. There's also a definition about interoceptive sensibility, which is more than just do you have interoceptive accuracy where you're accurate about your internal sensations, but what are the beliefs that you hold about those internal sensations? How do you respond to them? How do you react to them? And so a more of like self-report way of measuring internal sensations. And kind of in that area, there is this idea of interoceptive awareness as a form of interoceptive sensibility that's, I think, thought to be generally a kind of healthy and non-harmful way to pay attention to body sensation that has been measured with the Maya, the multi-dimensional assessment for interoceptive awareness, which has 8 different scales within it. And so within that way of measuring interoception, we're getting at how often do people notice their body sensations? How often do they listen to their body sensations? How much do they trust their body sensations? How much do they use body sensations to decide how to regulate their motivation or their actions? And then you can take it even farther. I saw there was a great question that someone asked, about Lisa Feldman Barrett's models of interoception around allostasis. And I'd say there's what interoception is and how science is defining it, and then there's what it does, what its function is, and how is it leveraged and utilized. And I think her models of interoceptive allostasis are really wonderful to show how interoception is used in the body to kind of predict what's coming based on prior experiences where we learn body sensations that are associated with different things out in the environment. And then based on that, we feel motivated to make changes and prepare ourselves for what's coming. And that's part of what emotion is as well, because every emotion has an interoceptive aspect to it. And it is that physical sensation that motivates us into emotion, into doing. So whether that's butterflies in the stomach with anxiety or feeling warmth in the cheeks with shame, every emotion has some interoceptive signal.
Yeah, I know you were involved with a systematic review that came out recently. I think Simon Goldberg was maybe the lead author. And then you and I, 10 years ago or so, got a big NIH grant together where we had matched randomized controlled trials where we matched our measures. And you were doing the mindful PC study in primary care patients, and I was doing the mindfulness-based blood pressure reduction study in people with high blood pressure. And of all the mechanisms that we looked at, one of the most consistent operators that came out in both studies was the value of interoceptive awareness, where in our study we found it was really important for people to notice how they felt when they ate different kinds of foods and how that was a mediator and how it actually influenced their improvements in their dietary patterns. And then I'd be curious for you to kind of share, like when you take a look now at the field that's, 15, 20 years in, what are you seeing are like the sort of silver bullets or like the blazing findings that are just quite consistent and quite important, kind of explained in a way that folks from pretty much any background would be able to understand, like really how this is working.
Yeah. So that review that came out in Scientific Reports this year was Isaac Trevis as the first author.
Okay. Oh, thank you. Yeah. Good.
And it demonstrated that across all the different mindfulness-based interventions that they tended to increase self-report mindfulness. Actually, in particular, our mindful behavior change intervention, which I'll talk about in a minute, tended to have, on average, the largest effect size on interoceptive and increasing interoceptive awareness, which I think might go back to some of the ways that we really built interoception, try to leverage that in developing the intervention. So, so this kind of capacity for increased body awareness, one aspect within that, I would say, is called interoceptive appreciation. It's kind of how much do we appreciate and value what's happening in our body in how we make decisions about what we do and in our lives. And so the body listen and body trust measures in particular were ones that we were interested in the mindful PC study. And what we found was that you could predict about 30% of who would be able to successfully make a behavior change, people with chronic illness in primary care, who'd be able to make behavior change based on how much change they had in this interoceptive appreciation. One thing that was different was that people without depression had these large changes in their capacity to listen to the body, and that seemed to be predictive of who would make a change. People with depression, though, tended to need to have increases in body trust in order to be able to make a change. And I think one of the things that's really important to look at is when you see dysfunction in interoceptive pathways in the brain, you see in depression in particular, compared to all the other body. I remember I talked about how all different emotions have an interoceptive signature. The one thing about depression is that the interoceptive signature is no sensation. And people tend not to feel their bodies. They tend to be caught up in their mind and thoughts about themselves, maybe the past, the future. But you don't see, you actually see there's like a tuning down in the brain of the insula, which is in this area here. It's the island between the frontal and temporal lobes, and it's a part of the brain where we tend to be able to feel our body in this moment, and it's where a lot of these interoceptive pathways end up in the brain, and you just see that being completely shut down when people that are trying to pay attention to their body in depression. As opposed to, let's say, anxiety, where sometimes it's actually ramped up and people are over responsive to body sensations, which is why there's no one good level of interoception. It's about finding the right level for yourself in the moment, and learning the wisdom of how to understand, how to integrate and regulate and respond to these sensations. There are two forms of interoceptive regulation: perceptual inference and active inference. People tend to think when they have a negative or unpleasant sensations that they want to change those sensations. And so they tend to try to take something or do something to make it go away. But in mindfulness, what we're actually training is perceptual inference, which is actually changing the expectation of the mind and the brain to be wherever it is right now. So, so there's less of there's less of what's called a prediction error between how we want things to be and how they are. And so, so we do see that people are able to train that capacity in mindfulness.
Question came in around, if you could elaborate on how interoception is being used to treat addiction. And so we can kind of see with depression, it might be on the lower side. On anxiety, sometimes it's maybe on the higher side when you need to find that sweet spot. And then what about around addiction? How does it potentially operate there?
Well, the data is just starting to come in around the interoceptive dysfunctions that we see in substance use disorders, and we do see different things for different types of substances. But we definitely do see interoceptive dysfunction. Saadeh has a paper about this. We do see dysfunction in people who have opiate use disorder, people who have stimulant or methamphetamine use disorder, and that is part of what we're trying to train people in. Let me take a step back for a second, and I'll get back to addiction. I think it's important, but I think just so you can understand the work we've been doing, we started together, 8 years ago, 9 years ago. We started the Mindful PC project. We integrated mindfulness into primary care across our healthcare system in an insurance reimbursable way. in a trauma-informed way. And we tried to develop an intervention called mindful behavior change, which could center things like interoception, but also self-compassion and an internal, and what we call like a warm mindfulness approach, but an internal and explicit generation of internal compassion and warmth. And so I think it's really important when we're talking about interoception to also focus on not just acceptance, but also our capacity for internal compassion. Because people can then get into their mind that, oh, like all interoception is going to be good, and I just need to pay attention as hard as I can to my body. And for many people, they're going to get overwhelmed. And in fact, you're going to come into contact with unpleasant sensations. And it really is about a slow process. And I don't know if there's any middle schoolers here. I apologize for doing this. They always laugh when I do. But there's a there's this kind of process of slowly increasing both your capacity for interoceptive sensitivity, as well as your acceptance for and equanimity with whatever it is you're experiencing. And I would add that compassion can be really helpful for helping to increase the capacity to be able to maintain equanimity in the face of pain and discomfort. Mm-hmm. And so in developing our intervention, we felt like it was equally important both to teach people about interoception, but also in this more mindfulness approach, teach people about compassion as well. So we had 3 randomized controlled trials, alongside the work you were doing, and they all showed increased the ability for people to make behavior change. So we took that intervention and tried to bring it then to opiate use disorder as well in primary care. I should say the primary care program that we had was integrating it both as group medical visits as well as group psychotherapy, depending on what the clinic's capacity was, taking a really flexible implementation approach.
Just for the audience, a group medical visit is offered by a clinician, immediately health insurance reimbursable. So you've been one of the leaders in the country around not trying to stuff mindfulness into try to find some way to find health insurance coverage for it, but just to say, this is simply how the healthcare system is, and how can I design something that would be immediately health insurance reimbursable? And the group medical visit method has been one of the ways you've done that I really respect.
That's right, yeah. So group medical visits are run by clinicians, usually medical doctors or nurse practitioners or PAs, and are insurance reimbursable in a very sustainable way. We also have another faculty member at our center, Paula Gardner, who's also been an innovator in the group medical visit approach. So I'm really glad that she came to join us and bring her expertise there as well. So we've been doing group medical visits for a long time, and also using group psychotherapy, depending on where the clinician and the clinical capacities are at. But we have been doing insurance reimbursable, sustainable in the healthcare system mindfulness implementation. And so we took that, and when we wanted to look at it in our opioid, people with opiate use disorder prescribed buprenorphine, and we did see increases in interoception in our pilot studies, and then in our larger study, we actually didn't see a difference across groups in interoception, but we also didn't see a difference between the group and the gold standard evidence-based approaches on primary outcomes so it was as good as gold standard addiction programs like motivational interviewing, CBT, and 12-step facilitation. But what we did see is that mindfulness outperformed on opioid craving compared to other interventions, which is similar to what we see, I think, across most substance use disorder programs. So what I would say is I do think that interoception has a role in the ways that mindfulness impacts craving, and may be able to help people to change the way they relate to their body sensations when they're having craving. And but some of that depends on how intense the craving is.
Hmm.
And are you in the sweet spot or in the window of tolerance within
Yeah.
which craving can be managed? And so again, our study was with people who had buprenorphine, so their craving was at the lower end, and we were able to see that people were able to utilize
Mhm.
mindfulness to be able to reduce that residual craving.
Yeah. Yeah. Just kind of even thinking about, interoceptive awareness and measurement of it. Like, how do we really know it's the feeling? Like Paul Grossman just submitted a question. What about the issue of how accurate are bodily perceptions? We know that many people, like fibromyalgia patients, perceive bodily changes that may only be aspects of brain interactions, not demonstrable actual peripheral changes within their bodies. This also occurs in panic disorder, social phobia. So, are there brain changes that correlate with actual bodily changes, which are both perceived, and then are there bodily changes that are ordinarily not perceived? But it's a big
Yeah.
question for sure, but I think it's kind of getting at measurement of
So,
self-report versus objective and brain signals, and how do we really
right.
tap into it?
There's some limitations in the capacity to measure this, and we're all trying to get a lot better at this. And NIH has recently funded over the last decade a lot of improvements in measurement, both in animals and trying to improve our understanding of these systems. What Saad Khalsa did a bunch of studies looking at, interoceptive accuracy, finding no differences in meditators from controls. But meditators tend to believe more that they are able to feel body sensations. So either we're not measuring the right thing in that, or meditators are wrong. Um, but one of the things that I've been saying for the past 10 years is that I don't think it matters necessarily, even if we're right or not, because we are tuning in and paying attention, which is why I'm highlighting this idea of interoceptive appreciation.
Mm,
Um, because we may or may not, may or may not be telling us we may or may not know exactly what's happening in some part of our body, but we might know that something feels like it's different, or something is off, or something is something we should get curious about and pay attention to.
mm,
Um, and it seems to be that the people that are doing that tend to be more likely to be people that were able to make changes. So while I'd like to believe that every sensation that I feel when I'm paying attention as a mindfulness meditator is like the actual true sensation, it's possible that there's also some sensations that are not exactly, what's there, but is some kind of prior experience that I'm trying to notice, and I might even be interpreting it in the wrong way. Um, but on a whole, it seems to me that paying attention to the body is still better than not.
mm,
Um, and uh, and figuring out and developing wisdom over time with your own body about what your sensations mean to you is, I think, in some ways, the definition of wisdom that's useful for behavior change, because you're understanding what your mind body system um, is trying to tell you.
mm. Yeah. Yeah, Emily put in a question. I feel like I feel like in our society, we're taught we're stronger if we ignore our body sensations. And have you explored this in eating disorders?
Hmm. So, eating disorders is one of the areas where there is, interoceptive dysregulation. That's not my specific area of focus, but there are a lot of people who do study that, and so I don't want to, I guess, speak to that too much, but just to acknowledge that it definitely is at play there. Um, yeah, yeah.
Hmm.
But it's not my area of research. I do want to talk about the trauma and interoception, because one of the things that Bessel van der Kolk wrote the book "The Body Keeps the Score," and this is partly how the body keeps the score, as you would say, from past traumatic events, is that we remember them as interoceptive sensations, and then when we get that feeling again, um, people who have had a traumatic experience can have a very, very strong and immediate reaction. Maybe it's a uh, you know fight reaction, maybe it's a flight reaction, maybe it's a freeze reaction. People have asked about those questions, and I think that and so in paying attention to the body, it's particularly important to take a trauma-informed approach and assuming that just about anyone you're working with has had some trauma that has some residual memory in the body. And so part of our developing the Mindful Behavior Change program was really trying to develop a trauma-informed approach. And we actually changed the kind of informal mindfulness acronym that we used. And we built it up over the course of the 8 weeks. It's called Stop, Ache, and Go. So we have people, and there are multiple times throughout, have people learn how to practice this informal practice throughout their day, where trauma-informed wisdom is kind of coming into the way that you use mindfulness. And I think that's important because we have people, stop or just slow down. T for the, in the T, just turn towards your experience. And if you can't turn towards to it, just try to take notice of your breath or your feet on the ground or sounds in the room. So there's always this kind of wisdom for options based on what would be skillful for you in that moment. Oh, observe what we call the diamond of experience. So not just your body sensations, but also emotions, thoughts, and urges that are present. And then P is becoming aware of the pleasantness or the unpleasantness or the neutrality of the experience. And this is a great way to actually work with interoceptive sensations, because even sometimes people can't feel their body sensations per se. They can tell if this is a pleasant or unpleasant or neutral moment. This is the Vedana in Pali, but which is really at the heart of being able to break habitual patterns. So we bring that in. And then so stop, and then here's the ache. And this is really helpful for people with chronic illness because there's often a lot of pain and discomfort, a lot of ache, but we're stopping, we are allowing ourselves to feel the ache. So the A is for allowing or accepting. But also if you can't do that, if you can't allow or accept it, can you just kind of anchor that in your breath? So there's always this kind of acceptance of other pathways that can be just as skillful for you in the moment. And then C, can you be curious about it? Can you, and if you can't be curious about it, can you recognize that everybody suffers common humanity? Or can you just bring compassion to yourself? Not because you're using compassion to try to make the feeling go away, but because you're recognizing that, like everyone else, you're a being who has some suffering, and this is a moment of suffering. And then H, can you hold that feeling? Or can you hold yourself? So again, can you just hold yourself? Can you touch yourself? Can you do something that elicits a soothing response like you would to a child you cared about or to a friend who is suffering? And holding that. And so there were some questions about, how does this relate to exposure and response prevention, for instance? Well, it is, mindfulness is an exposure practice where people are coming into the moment, noticing what's there in your full experience. And then, but it's not just about response prevention. It's, for some people that works, but if you have trauma or addiction, like, very hard to not have some kind of response. But how can we be with ourselves warmly while we're having that response and accept how that is and accept where we are and have compassion for wherever our system is in this moment. And then from there, so that's ache, and then from there expanding with gratitude, not just gratitude for the practice, but also gratitude for whatever was hard in that moment, because that's a teacher for us. Gratitude for our chronic illness. Osler is the founder of medical education, said health is a good health. True health is having a chronic illness and learning how to manage it. True health is not the absence of chronic illness. We're all going to have illness. We're all going to pass away. But true health is actually getting to have a chronic illness, that gift of a chronic illness, and then being able to learn from it. And this is the process of how you learn moment to moment in an informal practice. And then from there, go. So gratitude, and then opening to life's challenges and the opportunities with kindness. really trying to turn towards everything in our experience with that kind of kind, warm, being with energy.
Mm.
So that's
Yeah,
what
it's a
we're
powerful
teaching
framework.
in the mindful behavior change program, which is really trying to help people to get all the way with the practice.
Mhm. Yeah. Yeah, I've been impressed with your team's work on that, including Diane Joss, who's a junior faculty member with you, and know that we've got a symposium coming up at the International Congress on Integrative Medicine and Health in Utah in a couple months, all on the role of mindfulness training in folks with a trauma history. So in the past, like David Treleaven's done incredibly important work to help mindfulness interventions become more trauma informed. And now some of the evidence is showing that mindfulness interventions might actually be more effective in people with a history of trauma rather than without, especially if they're trauma informed. And so we've got that symposium with Shufang San as well,
Yeah.
coming up on that topic. And then just kind of bridging over to it, with you at Cambridge Health Alliance, I know that hospital system has a long history of serving folks from challenging backgrounds and immigrant populations and pretty diverse communities. And I know you've worked really hard to develop programs that include members of those communities in the design stage as well as in the delivery stage to better meet the needs of the population who your hospital system serves. And I wonder if you might share a little bit more around your work in that regard in terms of how you've really tried to look at the diversity of folks in the regions that you serve and how best to meet them with respect and inclusivity and including members of those communities in the programs that you develop and offer.
Well, the center started in 2014, and from the outset, this is the Center for Mindfulness and Compassion, um, with the goal of integrating mindfulness into healthcare and across primary care. And so from the outset, we knew that we wanted to do this in multiple languages, not just English, but we started adaptations in Spanish and Portuguese, working with local community leaders and also clinicians who were bilingual, as well as with collaborators in Zaragoza in Spain and in Sao Paulo, Brazil, so that if we were going to do that, that we would be able to implement this in multiple languages. You know, even with that though, we still found that because of the study criteria that there were certain people who were getting excluded from studies, um, perhaps because certain people from diverse backgrounds weren't showing up in getting treatment until they had pretty significant symptoms, and so there were some of those exclusions from the NIH, review process made it harder for people to be in those studies. So we started the Mindful Mental Health Service back about 8 years ago, and we've had about 9,000 referrals in that time to the Mindful Mental Health Service, and we run groups in English, Spanish, and Portuguese right now, and do have a accessible for diverse populations. But even then, we've wanted to go farther. We more recently, past maybe 4 or 5 years, started collaboration with the Mandela Yoga Project. It's named after Nelson Mandela. Jeffrey Thomas, who's one of project director for that program, developed this based on developed with yoga teachers of color a program called Sonia Sequence, named after his sister who died from diabetes and metabolic syndrome and wasn't able to do yoga, which he thinks would have helped her. And he's since been able to, his team has been able to both implement that as group visits in healthcare for Black women with hypertension and diabetes. And it's also gone further. We had a paper that we published working with men post-incarceration, men of color who had a history of substance use and were at risk of overdose. The Mandela Yoga is a really nice fit for peer-led, culturally resonant place-based
Mm.
implementation for in places that were comfortable for people to come and be led by peer leaders. So I think that work is essential. It really is one of the areas that the field needs to be focused on. Um, not just uh, um, and really working to understand um, movement, music, sound, other things that might be more culturally resonant, how those can be parts of groups. In our groups for Portuguese speakers, food was essential. We were told that if we're going to run this, there has to be there has to be people allowed to bring in food for each other, and that was culturally important. So I think it's beautiful to understand all the differences and what works and has meaning for different communities and populations.
Yeah. Well, thank you for doing that work. And
I want I want to add one thing to that, if that's okay. We last year we launched the Mindful Healthcare Scholars Program, which
mm,
was specifically designed to support people who are in healthcare professionals of any type of professional, or people who wanted to be or work with others in healthcare to integrate mindfulness into healthcare. Um, and um, this year we're getting ready to launch our second year of this. But helping people to, based on the skills and expertise that we have and faculty, not just from our center, but Eric, you also presented, and there are other presenters as well from other centers who have successfully implemented mindfulness. A lot of us learn about mindfulness. We take a mindfulness course, maybe we can take a teacher training, but we don't actually know how to implement it into the healthcare system in a sustainable, insurance reimbursable way. So for anyone who's interested in that, we do have our website. I'm happy to share it. The Mindful Healthcare Scholars Program from this year. We're going to be starting to accept applications on February 15th, and it is a competitive application, but we hope that we'll have a lot of great applications and from people. I saw something about uh, uh, um, what did I see in the chat about creative arts therapists, yoga therapists. Yes, anybody would be welcome to apply if you have an idea and a team who might be interested in helping to bring that into the healthcare system that you might be working with. So we're helping people to problem solve, to figure out how to do that with people and mentors who have done that successfully already. And I really think that's where our field needs to go, because there's a lot of great mindfulness opportunities that are available to those who can pay, to those who can access it online. But how do we get it accessible into the healthcare system, where it really is a central part of the healthcare system, whether it's primary care or mental health, addiction services, or across, even specialty care. We've had people from all across have expressed interest in being part of this Mindful Healthcare Scholars Program. So I wanted to welcome people.
yeah, I've appreciated your emphasis on teams taking it, because if there's one individual who wants to offer it within their system, but the system doesn't really get how to do the recruiting or the communication or the billing or to set up the visits, I think having a whole team go through it can be transformational, because everyone has their own role in order for the system within that medical practice to change. And I think you've really cracked that in a way that I haven't seen others crack, and are now offering that training to people too, which I appreciate.
We actually try to give, we so strongly believe in it, we try to give like a 50% discount to anybody who brings a second or third person on the team. So that way
Mm.
people are encouraged, because for us, when we started a site, we try not to do it with less than 2 people. You just it's so much easier to kind of stay motivated and be able to solve some of the problems when you're not alone and you have a community working on this together.
Yeah. Maybe just on the lighter side, this past summer, I know you completed the last of New Hampshire's 4,000-foot high mountains. So there's 48 of them in New Hampshire, and it's like a thing in the Northeast to like hike all 48, and you did it. And I'd be curious to hear, a little more about like
Mhm.
what that experience meant to you
Yeah.
personally, and how it shaped or deepened your understanding of mindfulness or embodiment or resilience. And
Do
just
I?
to mention, my wife and I were so delighted to be there with you when you reached that summit with your wife. And it was really
Eric, you are
moving.
the only friend I had that was willing to go in 31-degree weather to the top of the mountain at the end of September. So thank you to you and your family
Oh,
for
it's
coming with us.
delightful. Yeah.
How much time do I have? Because I have an important response to that question.
Yeah, we've got till 12:52 when we need to kind of transition a little bit. We've been bringing people's questions in all the way through, so we've
Well, let me
kind of got this sprinkled in here.
let me just say, I mean, the thing I haven't had a chance to talk about throughout is that part
Yeah.
of this focus on chronic illness and behavior change started with myself. Um, back in 2011, I had pneumonia and injured my lung, and I got a diagnosis of non-cystic fibrosis bronchiectasis. And when I looked it up in the book, it said you have 4 years to live. And that was the moment that I decided to leave what I was doing. And when we started to try to make CMC, or the Center for Mindfulness and Compassion, and start to focus on chronic illness, because despite being a very intensive meditator, I'd been on 10 Vipassana retreats. I still got sick. I thought it would protect me, but it didn't. And part of that was really needing to learn about compassion for myself. And anyway, I guess this is another talk, and I'm happy to come back and really talk about the personal aspect of things if people want. Um, but um, but for me, after 10 years, I found myself 2 years ago not being able to walk 100 feet, um, because the lung disease had progressed, and I had infections with antibiotic resistant bacteria that no one thought was going to go away. Um, and and so for me, the ability to go 2 years later to now finish the 48 4,000 footers, meant a lot to me. Yeah. So
Yeah.
I appreciate you asking about that, and I think a lot of that has to do with the idea that, if we can stay mindful and compassionate with where we are, um, a lot can change. And um, and in my case, a lot has changed. That I could go from not being able to walk 100 feet to be able to hike up this 4,000-foot mountain. Actually, we did 12 that summer, so I figured this was my window of health. I should take it while I can. Um, so so yeah. So anyway, I'm I'm still alive, 13 years later. So I think I beat the prognosis, and I'm actually feeling quite good now. And I think that the um, uh, I think that the mindful behavior change program is a big part of that, and being able to figure out how to, um, not push myself too hard, but be able to, um, be able to, again, get to this place where I'm bringing up both my awareness with my equanimity and my compassion for myself.
Yeah. Yeah, if I can maybe share some of the things I've seen just briefly, but I think it was 2 summers ago we were with our kids hiking up a bank on Jamestown, which is an island in Narragansett Bay, and the coughing that you had, that was really something to me. I think that was maybe at your low, and that was just, a 75-foot bank that we walked up, and
Yeah.
to now see you be doing all these 4,000 footers, and I guess, I think of you as a world leader in mindful behavior change and interoceptive awareness. But I also feel like you walk your talk, so that there's been all these different potential types of treatment for the lung condition. And I feel like I watched you systematically try every single one, really dig into the evidence or the lack thereof, and to not hesitate to go for what might solve it. And to see you go to that lung clinic nationally recognized in Denver and to try an experimental treatment, that was the thing that worked. And
Almost.
now, 2 years later, here you are. And so I think I just have a lot of respect, not only for your ability to change your behavior, to try these different things, but then also your ability to have that body awareness to see whether that behavior worked or not. And if it didn't, it's good data, move on, try the next one. And I think you really embodied that and are now having a thriving life, showing the ramifications of having embodied that.
Well, one of the things about surviving was that I had to make about 13 different daily behavior changes, um, and just to stay alive. And then even with that medication, it wasn't just that. Like there um, there have been so many others as well that have had to be made when you come back from the brink, and now it's not, then you can refine it more. There's a lot to pay attention to, both in the diet and the way that you move your body, um, and to figure out, yeah, which medicines can I get rid of because they weren't doing anything. um, and more than anything, just really learning to listen to that signal of when my body's telling me it's enough.
Yeah.
You're too cold, you need to get warm. Or this is the moment when you need to call to get antibiotics. But we're seeing this now actually with that mindfulness interoception is likely playing a really important place in people's capacity for self-care of chronic illness, whether that be heart failure, being able to notice if you're in volume overload, if being able to notice what it feels like when the feet are swelling or when it's a little bit harder to breathe, and to be able to act on it right away. It's about getting that self-care there in the moment when you need it, and stopping the other behaviors that are distracting you or taking over. And part of what we're looking at now research-wise is looking for collaborators who have expertise in various different chronic illnesses, who want to study the role of interoception and self-care, because our mindful behavior change and intervention is, in the meta-analysis, the most impactful of all the interventions as far as really leveraging interoception and interoceptive awareness. So we are, hoping to develop more collaborations and beyond some of the chronic illnesses we've been looking at, and that's one of the next steps for us.
Good. Yeah. Yeah. We, as I mentioned, we start and stop with the same questions in each of these speaker series. And the closing question for this one is, looking ahead to the future, where do you see the study and practice of mindfulness best serving humanity?
Mm. Well, I mean, I guess I'll come back to the mindful healthcare scholars program. That this, capacity to integrate mindfulness into healthcare, I think is essential to make it accessible to everybody. Um, I think that um, I think that the integration of compassion with mindfulness. And when I started, I was an engineer, as I said, compassion was quite woo-woo. I don't know if I would have started practicing if I knew how important that was in the work that we are doing. And at the same time, I feel like it was the integration of mindfulness and compassion that really helped to save me with chronic illness. And I think it's really important that we continue to look at that. I think the work with adverse childhood events and childhood maltreatment and the impact of childhood trauma that we see in so many people, and the self-critical rumination that comes from it, and that mindfulness does have a capacity, I think, to mindfulness, self-compassion has a capacity to kind of turn to change that. And I think one of the reasons why that's so important is because shame is such a toxic emotion, not just for ourselves, but for our community, and it tends to lead to responses of hatred and anger in response to cope with it. And I think part of what we're seeing in the country and perhaps across the world is the kind of just the impacts of shame externalized, um, and I think we need to figure out how to reduce internal polarization inside people, where we get polarized um, between aspects of ourselves that feel hurt, and aspects that maybe are critical of that, and critical of ourselves and critical of others, and shaming. Because I think the more we can create internal harmonization instead of internal polarization, the more our communities can have more harmonization instead of polarization, the more our country can have more harmonization instead of polarization, and ultimately our world. So I think doing this internal work is essential. We've started to also do research on the internal family systems approach, which was a integrative therapy that was developed, that we're now finding it engages many of the same mechanisms that mindfulness does, the mindfulness-based interventions does, just in a slightly different way, and in a way that makes it even more accessible in our experience for people who have severe trauma and complex trauma, because it's reducing this internal polarization and getting at that directly. Truthfully, I think that the two, mindfulness and compassion training and the IFS training, they all kind of work really well together to be able to help to start to understand even more what our responses are and our behavioral patterns are. So for me, it's been a additional kind of insight practice that's been able to add to my mindfulness and compassion practice that has aligned really well. And I do think what it does is it really helps to make the internal world more harmonious. Because for me, with my chronic illness, I felt ashamed. I felt like I was broken. And I wanted to hide that from people. I didn't tell anyone for probably 2 or 3 years how sick I was. I didn't really tell myself, honestly, right? And so that's the polarization. And so part of being able to reduce that polarization and allow that kind of internal compassion and that internal warm mindfulness presence to really come through just helps the entire internal system to and to organize and to be able to become more effective in self-regulating and making behavior change. And I think that that's not just true for health, but likely could be true for our country, for our community, for our country, and our world.
Yeah, I'm just aware of the time here, but we often hear about polarization in society, but I think the idea of polarization within ourselves too is not talked about a lot, and appreciate the idea of like really fostering healing in that regard. And just want to thank you for all the work you're doing. There's lots more we could talk about, including the dedication you have to training the next generation of scientists too, including postdoctoral fellows and junior faculty, that I've really seen you create a very healthy environment there, along with the important research you're doing and how you embody this personally too. So just want to thank you for visiting us today, and thank you for all the work that you do. And it's really been a pleasure.
Just want to also invite your listeners to join us at our Grand Rounds series, which is every other Monday from 1 to 2 Eastern time, where we I think are also trying to do the same thing. I really appreciate what you're doing here of trying to just get some of this work out there, and it's free and easily accessible to all. So
thank you. Fran, any last closing elements?
Thank you so much, Zev and Eric, as always, for facilitating, and thank you for everyone for joining online. I wish we could go longer. There was much appreciation, Zev, for your sharing of your story and for the emphasis. I really appreciate the emphasis on self-compassion and harmony as well. So I dropped the links to the upcoming events. We hope that you can join us. We'll send out a link to the recording. And I also realized that there was a number of resources that were mentioned quickly during the talk. So Zev, I'll connect with you by email, and maybe we can get that out to the audience, including some information on the symposium and training programs mentioned as well. So with that, thank you, and be well, be safe, and we'll see you next time.